Hi, everybody. Welcome to February 2024, our expert interview for the Pelvic Health Explorer. Today, we are excited to be able to bring you Dr. Allison Quick, who is a board-certified radiation oncologist at The Ohio State University Wexner Medical Center. She specializes in treating women with gynecological cancers. Her research interests include cancer survivorship, particularly vaginal and sexual health after cancer treatment. She also obtained a women's health coaching certification through the Integrative Women's Health Institute. Welcome, Dr. Quick. We are so glad that you were here. And let's open it up. Tell me a little bit about the work you've done looking at vaginal health in cancer survivors.
Sure. Well, thank you for having me. I'm excited to be here. As you mentioned, a lot of my non-clinical work has been around cancer survivorship and improving women's quality of life after cancer treatment. Not all of that work, but a lot of it has been around vaginal and sexual health, some of which has just been looking at sexual health outcomes in women who have radiation treatments. And also, I have been able to conduct some larger clinical trials using fractional CO2 laser therapy or Mona Lisa touch in two groups of women, both in the breast cancer population and in the gynecologic cancer population. So those are two of the groups that I am very passionate about helping. They have different reasons for having vaginal and sexual health problems, but it's a common issue amongst both of those groups. Yeah, so that's most of my research work. I also serve on the board of the Scientific Network for Female Sexual Health. We're planning a big annual conference this year at Ohio State. It's a group of women who are interested in advancing education and research on female sexual health. So if anyone in your group is interested in that group, it's a great group of collaborators.
Great. We'll put the link down into the show notes. So people, if you're interested, you can definitely chime in. So tell me about a little bit more in your research. You were talking about the two groups. Tell me about those two groups and what you have done with them and what you're hoping some of the outcomes might present with your research.
What specifically with the work that was done? Yeah, so, in the breast cancer population, these are a group of women that have a lot of vaginal changes because of their need to either come off of hormone replacement therapy as part of their cancer diagnosis or as part of their cancer treatments, which can include chemotherapy or anti-estrogen therapies, which may require, 5 to 10 years of treatment beyond their diagnosis. And a lot of those women experience vaginal dryness and painful sex because of the decrease of systemic estrogen and how that affects the vaginal tissue. The studies that we have conducted so far were limited to single arm observational trials. We did see some preliminary benefit both in patient-reported outcomes and in sexual function. We have been working on developing a larger randomized clinical trial in that setting, as it's a controversial treatment. And a lot of women pay out of pocket to have this treatment done, as it's not covered by insurance. And so we are hoping to find some evidence to continue to support women having this done. It does seem to be safe and not causing any complications. In the gynecologic cancer population, the treatment is a little more complicated because the vaginal changes are for a different reason, predominantly because of either surgery, hysterectomy, or because of radiation treatments. And it's a very different mechanism of, of the reason why women are having vaginal dryness or painful sex. And a lot of that's because of the direct treatment effects on the vaginal tissue. The study was, again, a small pilot study, which just shows some preliminary evidence. Around the time the study was being done, there were some changes in the FDA specifications about how these devices could be used. And so we did run into a little bit of logistical trouble with some FDA regulations. And so we're still working on sorting some of those things out to be able to continue. We did find that the treatment was safe and preliminarily did show some benefit in sexual function when those treatments done.
So far the treatments have looked like they might be promising as an
Yes.
alternative form to other traditional ways for treating vaginal dryness and post-cancer. So breast cancer is more of an indirect result of vaginal dryness and tissue thinning because of the loss of estrogen in the system, whereas definitely the radiation and surgeries right into the pelvic area are, is a direct assault on the tissues that, create a lot of these changes, fibrosis, and different types of things. Before we get into, what we need to look out for as pelvic health providers, as maybe some red flags or reasons to continue or when we should consult radiation oncologists, what it like, what is the gold standard right now for is topical estrogen? Let's talk about breast cancer or other cancers that aren't affecting, that aren't directly assaulting the pelvic region. Is estrogen topicals safe, not safe? Still, I mean, I know that there's been some randomized control trials that say the systemic uptake is very small, but yet it's not being used widely in this population. And I think traditionally it's like talk to your oncologist, talk to your radiation oncologist. So what are your thoughts behind that, and how do you direct people?
Yeah, I think everything you said is correct. It's pretty controversial, whether not necessarily even based on the data, because I think that the data has shown what you said, that there seems to be very low systemic absorption from a vaginal estrogen product. Um, However, there are a lot of concerns amongst clinicians in prescribing that medication for their patients. So I think it's very oncology provider specific. I have seen it used, especially in some lower risk patients with breast cancer. So it is typically a discussion between the oncologist and the patient, depending on how bad their symptoms are. They will typically suggest trying alternatives first, such as other vaginal moisturizer products, or vaginal DHEA or other things like that first. And then if the symptoms are really severe, impacting quality of life, and the patient understands that there may be a small risk, then a lot of providers are willing to, have their patients have that treatment done. Again, if it's a kind of risk benefit and the patient is fully informed. But typically our, gynecologist will consult with the oncologist first before prescribing that, just so that everyone's kind of on the same page and the patient's on the same page and discussion. Other cancers outside of breast cancer that aren't driven by estrogen should be completely safe. So even other gynecologic cancers where maybe the woman didn't have radiation to the pelvis, but they had a oophorectomy, which put them into early menopause, or like a cervical cancer, those women should be eligible for not only vaginal estrogen, but systemic estrogen as well. So it just really depends on the cancer and the individual's exact, situation. So definitely a discussion with patient and oncologist.
Yeah. And is there a timeline, like 10 years post, it's probably okay? 5 years post? I know sometimes with breast cancer, if they're doing tamoxifen or the aromatase inhibitor, um, they can be on that for 10 years. And they're not happy usually when they're on these drugs, for sure. But this is a major complaint that we hear. Is there a timeline, like once they're through with all of that, it's safe? Is it still a conversation they need to have with the oncologist or the urogynecologist? Mainly because that's coming up in our own sessions with us. It's like, well, it was 15 years ago. I should be fine, and we want to be sure that we're giving the proper advice, or at least, what is the consensus out in the field as to Is there a time, or is it still something that should be considered?
I'm actually not sure if there's an exact answer for that. I don't think there's actually a time thing because breast cancer in particular can have recurrences very late. So we see recurrences 15, 20 years after their
Mhm.
diagnosis. That's less commonly seen with other cancers, but it is something we see with breast cancer. A lot of women's symptoms hopefully will get better when they're off of the medication. So if there's 10 years they've been on an aromatase inhibitor for 10 years and they come off, hopefully things might get a little bit better, um but it is a common reason why people actually discontinue those medications is because they're so symptomatic. So we want to encourage compliance with their medication to take it for as long as directed, but still helping them with their side effects. But yeah, I don't know that anyone has said that, well, after 15 years or after 20 years, it's fine. I think everyone will feel a little more comfortable with people using them after that long. Um, but there's nothing specific that I'm aware of.
Yeah. So again, it's just a matter of being informed,
Yeah.
having a conversation with your healthcare provider and, if directed back to even your oncologist from before or an oncologist to just make sure that nothing has changed out there as far as what the recommendations are. A lot of people are talking about bypassing the estrogen and kind of going up the chain and looking at being able to make topicals out of products like DHEA. Is that considered a bit safer than estrogen, or does that fall still under the same umbrella, like we just don't want to introduce hormones back into a system that the cancer was hormone sensitive?
Our oncologists often prescribe DHEA, fractional topical products for their breast cancer patients. I
Okay.
just seen it started to be used in the GYN population.
Yeah,
But yeah, that is something that our oncologists seem to be more comfortable with as well.
because there's a lot of products coming out that are
Mhm.
featuring, the DHEA, as this, for people who just have, even people who have the history in their family. Some people have, like for me, it was a mother, a sister, and an aunt. And so I've stayed away from estrogen everything, on purpose because I just fit into that category. But DHEA has always been something that I use the Jolva product from Dr. Annika Becca, and I love it. But there hasn't been much of a consensus out there discussing it. So if the oncologists are kind of like embracing that a little bit, that's a great perhaps alternative, because sometimes the moisturizers are wonderful, but they don't help with the tissue, the thinning tissue and the piece that, can be so often accompanied to that. And pelvic floor muscle exercises only go so far. So having whatever they can to help, bulk up the area, can be helpful. So that's great. So the DHEA could be something that they could really have a positive conversation with you or their oncologist or their gynecologist or urogynecologist and get some better information on, which is good to know. So so let's talk a little bit more about people who have had radiation to the pelvis, whether it's, back passage, vaginal, any part of the perineal area or to the pelvis in general. So a lot of people will come to pelvic health providers, following radiation, because of stenosis of the vagina and or of the EAS or anal canal. And any kind of treatment, the tissue is like friable, it's really fibrosed. What are When do we worry about doing things? Because generally sometimes when we work with them, there is some bleeding because of the tissues. Is that okay? Is that not okay? Like I think people are just always a little bit nervous around that they don't want to do certainly any more harm, but we need to, maintain a vaginal canal opening for many reasons, especially exam, but also people need to have bowel movements and all don't want to end up with stomas and us, ostomy bags and things like that. So, like, when are things okay? When are things like, when should we be consulting and asking questions? What are your thoughts around that?
Yeah, that's a good question. I suppose to some extent it probably depends on the time frame from the radiation. So, ideally, I mean, in an ideal world, we would hopefully prevent a lot of these problems from happening, which would be seeing pelvic floor PT before there's a huge problem. I've been a huge proponent of having a lot of my patients who are really high risk for fibrosis, for a lot of vaginal stenosis, to be seeing pelvic floor PT, pretty close to finishing their treatments or kind of after they've healed. And because what happens is that as the initial response to radiation in the tissue is a lot of inflammation, and that inflammation will stick around for about 2 to 3 months after treatment's done. And as the inflammation is healing, the tissue that gets radiated, whether it's the vulva or the vagina, rectal and anal tissue, is
Mhm.
developing scar tissue as the collagen and elastin changes and the extracellular matrix kind of reforms, but it heals like aberrantly and not normally. And that is the process that will lead to fibrosis that can be very challenging to reverse once it's really set in. So the fibrosis process happens over the first 6 months to a year after radiation is completed. Um, and it will be normal for the tissue to be fragile, to bleed easily. So I don't treat GI cancers, but it's all kind of this, similar. So for a woman who's had radiation to her vagina, for example, if she doesn't, um, even if she is proactive with her vaginal health, but particularly if she isn't, and you go to do a vaginal, speculum exam, it is highly probable that she will have some spotting, and that is in due part and due to the tissue has become again fragile a lot because of the radiation, also because they have also gone through ovarian failure. If they were in a menopause before the radiation, in addition to directing the vaginal tissue, will also put the ovaries into it causes ovarian failure. So it's kind of a double hit of the woman is now suddenly into menopause, and their vaginal tissue has gotten radiation. The tissue itself forms what we call telangiectasias, are really thin. Like the blood vessels are very close to the surface of the
Mhm.
tissue. This is something that's visible on exam, and it just bleeds very easily with contact. So I would say a little bit of spotting, a little bit of bleeding is probably nothing to worry about. I would worry if it is more than some spotting, or if it's something that um, seems to not stop. I would expect anything normal should stop pretty soon after you're done with whatever, whether it's an exam or part of their physical therapy.
Right, right. So, especially for that first 6 months to a year, when you say the inflammation in the tissue healing that occurs after radiation, I think everyone that's listening is aware that the effects of radiation, um, continue on after treatment. That's the whole purpose behind it, is to make sure that the fields are clear and everything has been taken care of, and so they don't have their final radiation treatment and then, okay, everything's going to start healing. It's like it continues. It's a cumulative effect for sure. You talked a little bit about early physical therapy or early pelvic health therapy. um with radiation, do you send them prior to, so they can get started with vaginal dilators and stretching, or during radiation, or do you usually wait until, like, you're through with radiation, now go start with pelvic therapy before 3 or 6 months down the road when that fibrosis really starts to set in harder? Like, kind of what guidelines have you been following?
Yeah, we usually start. So I usually don't do anything during treatment, only because women are typically pretty sore. So if you're radiating their vagina directly, they're typically uncomfortable. Maybe not during the first 2 weeks or so, but by the fourth or fifth week, they're, probably not really going to want to use a dilator. Also, again, this process, the time during radiation is really just inflammatory. That fibrosis process hasn't really started yet. So theoretically, that fibrosis process isn't developing as the treatments are going on. So we feel like there's a little room to wait, let them kind of get their treatments, heal. Also, if they use, say they have a cancer in the vagina or in the cervix, and they're using a dilator that could be causing bleeding just from irritation of the tumor, like if they haven't, the cancer hasn't gone away yet. It's gonna be very distressing for people
Yeah.
because
Yeah.
bleeding is often a sign of, how their cancer presented. So they really don't want to see that because it freaks them out. So it's best to kind of let that all heal up. Usually when I see them we see them 1 month after their radiation is done.
Okay.
Most people are feeling a lot better. At that point, we introduce vaginal dilators, provide them to our patients along with instructions on how to use them. I would, in an ideal world, I would send everybody to pelvic floor at that point to go and to learn. I have found, and I actually at one point a few years ago tried to, I had a kind of a multidisciplinary clinic with myself and the pelvic floor physical therapist, and they would see me and then they would see pelvic floor. And what I found is that at that one visit, we offered them additional visits with pelvic floor. Some would take up on it. Some were fine just with like the one-time education. The continual problem is that compliance is very, very low with the vaginal dilator recommendations. But for those who are very motivated, who want to be sexually active, or other reasons to have comfortable pelvic exams, and they go, I do like to start them within about that 1 month after treatment time frame
Yeah.
to get
Okay.
them established, to find the right size dilator for them. Most women also need Kegels and have some underlying urinary incontinence issues just that were there beforehand. Maybe got a little worse with radiation, so a lot of them benefit from that as well. And I have, again, a handful of patients who've been very compliant with that. I wish there were more. There are women who are compliant with their dilators, but to have women be compliant with the pelvic floor physical therapy program in the population, my patient population has been challenging. A lot of our patients travel, 2 hours away to come for treatment, and they aren't local. And that's just been a huge barrier to care. So we've been trying to find some other, more community facilities around so we can plug people in, because people don't want to drive 2 hours just for pelvic floor therapy, unfortunately.
Well, if you think about it, though, these people have already been to so many providers and have been in and out of the hospital and have had chemo and have had radiation. And you have to respect the fact that they're probably just like, at some point there has to be when does this stop? What can I do on my own so I don't have to yet keep traveling down here or keep putting people out to bring me down here. And, unfortunately, there's not enough services in this country to help everybody who needs help. We just did an interview last month with Jessica McKinney, who talked about population health and how we have to step out of um, our conformational bias that we as pelvic health providers are the only people who can do this for people, and really start stepping into the space that I love what you were just saying. First of all, they're getting dilators where they need to be getting them from somebody they already trust who has been radiating their pelvic area. And so there's an element of safety and trust, which is one of the 3 things that people need to make changes. They need safety, they need relevance. It's relevant for them, for those especially who want to have sex. You just brought that up. And how can we make it more consistent without them having to travel? And even if they go to pelvic floor physical therapy or pelvic physical therapy or pelvic health, whatever we want to call it these days, once a week or once every 2 weeks isn't going to change anything. It's
Yeah.
gonna need to be what they can do on their own, and it strikes to me that if a lot of people are out there listening, and I love what you're saying, here, is what if there was a way, what if there was a program, an app that could be developed, like, teach, uh, radiation oncology nurses or them, and you probably already know this, you probably have already self-taught, which is gonna be the dilator appropriate for you. Here's the one that actually is not gonna be irritating, you wanna work up to this one and this one, and here's the program to follow. It doesn't take much, just a few times every day, giving people and empower them and maybe follow up with providers with telehealth, so that they don't have to travel, especially, they're coming from these rural areas in to see you in Ohio, and there may not be anybody out there that, but there could be maybe some sort of digital health or ways to, be able to have a 15-minute conversation. How's it going? This really hurts. I'm spotting a lot. Why don't you back down the dilator? Why don't you try it this way? Just to give some thoughts and help and have less of a hit on their financial services and on the insurance. But I love what you're thinking there and how you're talking about that because I think if we all get together and think more along those lines, we're going to be better for it. The pyramid of population health is what can we do down at the bottom of the pyramid more? Like it's great to be at the pinnacle where you get that one-to-one care, but is that it's not always possible for everybody. But we can reach so many more people with some good information and good help, even if it's just check-ins on an app that can be, that can keep people a little bit more consistent and, feel like maybe they would stop in and check. So I just wanted to kind of throw that out there because I think the way the world is going is we have to consider how we're going to reach, because we're talking about quality of life here now. We're not talking about, you have to do this because if you don't, now it's more like, this can we show you how this will make your quality of life better? And can we help you get that without having to like jump through 20 more hoops that you had to jump through just to get to this point?
Right. Yeah. Yeah, and it's important for women, a lot of women out there, when they're done with cancer treatment, it's as you said, they're kind of tired, they're done, they don't want to do anything. A lot of women don't, even though we tell them the rationale for using a dilator, they don't understand, or they think they like never want to have sex again. They're like, I'm
Mhm.
not worried about that. I don't care. Or they don't have a partner now and they think that's the way it will be for the rest of their life. And so, we try to also reinforce that it is for good, comfortable pelvic exams, that we need to see their entire vagina for their cancer surveillance. What happens, and there's some really interesting MRI um, uh, imaging of what happens at the very top of the vagina after someone's had cervical cancer. And basically that's, the vaginal apex just kind of agglutinates together and sticks together. So when so it actually kind of covers up their cervix. You don't even see a cervix anymore. It just looks like they have a vagina. And the more that the more agglutination there is and the longer the amount of the vagina is that's kind of adhesed together, scarred together, you don't see very much on your exams. And so it's harder to pick up recurrences. It's harder to really know what's going on with people. So we try to, educate them that it's really for both and to not assume that you will never want to be sexually active again because things change.
Mhm.
And people will have these assumptions and then they kind of wait too long. So, if you wait to start using a dilator, for a year because now you have a partner or things are getting uncomfortable, it can be really hard to reverse at that point. And so, it's really good to just to continue to try to educate, but also to meet people where they are. Because I've had people who are like, "Well, I have no privacy in my house. I'm taking care of my grandchildren live with me. They sleep in my bed with me. They walk when I'm in the bathroom all the time. Like they have like no privacy to like even use this diet later, right? So it's not always as easy as we think these things should be for people. So you kind of have to take their whole like each individual, in the context of where they are and try to figure out how to help them.
Yeah, and I think and that's absolutely 100% what we run into in pelvic health too, is many of the reasons people don't do things aren't consistent with, at home interventions is, first of all, they just don't want to do it. Second, they don't feel comfortable or safe in their environment to do it. Not that anything bad would happen to them, but their own barriers, or I don't want people to see me doing it or know what I'm doing. They want some privacy around it. And, you know, it's always interesting to have the conversations with them on, if it was a perfect world, where could you be? Or it's not a perfect world, where is the one place you can actually be? Many times it could be just in the shower, with the shower curtain closed and the foot up on the bathtub rim, and they can, they just places where they would never imagine doing it. It could be, but we have to have those conversations, and, having more information out there so people can look at this and go, "Oh, I didn't think about doing it here. I didn't think about this," because, when you're in the middle of it, you don't know, you can't see it. Just like, I'm not laying on my bed and doing this. There's too many people who walk in and out. Then, I mean, then it's like the conversation's over. Whereas, trying to meet them where they are and what's going on. But yeah, um, there's and again, they're still dealing with an area that, the safety and medical and diagnosis and, just the whole cancer word, and the, kind of like, when will it be over? But I love the fact that you're working and doing like a sexual medicine conference and bringing this part in, because how do we really communicate with our clients that you may not be wanting to be intimate right now, but you may want to be at another time in your life? Humans are built to be intimate. We're driven to be intimate. It's part of our neurochemistry. And, we to shut that part off of your life is like almost removing an appendage or a piece of who you are. And so keeping the door open, like, I love what you're saying, as far as like, if we could just get them to understand that we don't want that little tip of the vagina to close off over the cervix, that would make things so if they could at least just kind of communicate, that one, that your goal is to just to keep this open, not maybe do all this other stuff and craziness, but just to keep that open, so that it's like, when you heal a cut on your hand, we want it to heal nicely and we want it to be movable. The same thing here. Now you have some healing to do, and we want the tissue to remain movable and, not scar over and make it difficult for people to do the follow-up care that you deserve, to have. So, this is great. I think we've covered just about everything, except that I wanted to circle back to, the part you were talking about earlier, with the, fractional CO2 laser, the Mona Lisa Touch. What are tell because a lot of people just aren't aware, number 1, of what these things really do, and why you all selected them for this bigger study, and, what you're seeing with these things.
Yeah, so I mean, the caveat again, it's very preliminary. So I, can't say that for sure you should be like recommending these to your patients. But I think if there are people in private practice who, have these lasers and are typically available. Again, it's typically out of pocket costs. I haven't heard any changes on that. They are marketed, to the general population as kind of this vaginal rejuvenation.
Mhm.
Um, and what has been seen is that in the postmenopausal woman, that it's not actually laser, it's an infrared radiation source of very low energy, nothing like a therapeutic radiation, but it kind of remodels the extracellular matrix of the vaginal tissue and has been shown to kind of restore the vaginal tissue to more of a premenopausal state. So again, is that right? The moisturizers and the lubricants don't help the underlying problem. Even a vaginal estrogen, which helps the tissue, if you stop using them, the benefit goes away, right? So these also require compliance, long-term compliance. And vaginal estrogen is not cheap either. So, it's this ongoing, you need to use a topical vaginal estrogen for the rest of your life. I mean, it's hard to maintain, right? So the rationale is that these treatments, typically they're done 3 treatments, like every 4 to 6 weeks. That the theoretical benefit is that it can provide that change in the integrity of the tissue, but that can be longer lasting. What isn't totally known is if those treatments need to be repeated. So some people look at doing kind of what they call a booster once a year. So people who tell me who do these treatments, tell me they are wonderful. They can see the benefit, the change in the tissue, and that women really are benefiting. The data, the research data is controversial, and that it hasn't been proven to be better than topical products. So I think in order to, definitely say that it is an appropriate treatment, we still need to wait for more data. I think it is promising. I think it is worth encouraging our patients, if there are clinical trials available, to enroll in them. Again, it is definitely, we have not had any complications with it. And so from a safety standpoint, it, appears to be very safe. The lasers were there was initially a contraindication for women who had radiation treatments. And so, but, when speaking to the company, that was really just based on concern for what, the radiated tissue and putting the lasers in. We had about, blanking on the exact number. I think it was around 20 people who had radiation to their vagina, and didn't have any problems. But again, it was very preliminary data.
Mm-hmm.
Some of the issues again were because the FDA came out a few years ago. All these studies were going on, and that the marketing, while this device is FDA approved, it is not FDA approved for kind of this vaginal rejuvenation as it's been marketed. And so that has caused some issues with the ability to conduct clinical trials, because it is a big workaround with the FDA. So its treatments are still going on in private practices, and it's something that you could consider telling your patients to look into. Again, whether or not it is proven to be beneficial, I think is still out there. But again, the hope was to provide a treatment that can help the underlying problems without having to continue to use a topical product.
Right. And as you were talking about the topical products, it's tough to get people to use them, even though the benefits are so good.
Yeah.
Oh, I don't know what it is. We've got to figure out a way to make it more relevant for the consistency, because I think they feel safe with them. I just think the consistency isn't there, and I think the relevance isn't there. I don't know. It's just like there's a missing piece in there. And I know that the stuff around the vaginal rejuvenation has been controversial. People either love it or they hate it. I think it's wise to dive into the literature and learn as much as you possibly can about it, especially if you're having clients who are asking about it, or contact some of people like you who are actually doing the research, not finding any adverse effects at the moment. Did you, I'm just wondering, kind of getting back to that whole vaginal dilator piece and making sure that we don't close over, where if there even still is a cervix, or whether it's not, we still want to be able to swipe and get tissue sample and things like that for, future screenings. Um, do you think there's a place for this to help with that in the radiated vaginas that might keep that from going forward? Is that one of the parameters you're looking at, or is that something kind of you're like hoping, that if you could prevent that in the first year, then perhaps maybe we've got a shot to keep them going,
Yeah.
much longer?
Yeah, I do think there is um, there is some potential benefit. The other concern, which have not tested it in patients who've been like the most heavily radiated, so which are the people that we also see the most complications in, just because and the
Mhm.
tissue is very fragile and different for a woman who had with like an advanced cervix cancer who had external radiation and brachytherapy. There
Mhm.
is some pretty intense radiation to the top of the vagina. We did not include those patients on that trial because of concerns for how the treatment would affect that, just from a safety standpoint. So the patients who we did include in that pilot were much lower levels of radiation. So that's a huge caveat to that. I think I would like to see that work going forward more. We are also looking at the vaginal microbiome in patients. So we're doing a pretty cool study right now where we're looking at it's collecting a vaginal microbiome swab before radiation and then at time points for up to 2 years after radiation is done, and doing some exam measurements and quality of life assessment. So we can really see like when the changes are happening, what patients are reporting, and kind of how this correlates with their vaginal microbiome. And then from kind of once we get that data, we are hoping to then do our next kind of intervention study. Maybe that's laser, maybe that's some type of probiotic supplement. So we're kind of choosing our next step on the next intervention we want to look at, kind of based on the results of this study that we've finished accruing to, and we're just we have some follow up to do. So that's really, I think, going to be exciting. I do think the estrogen replacement is really big for a lot of these patients. It's something that providers are not good about. For example, since I'm not a gynecologist, I prescribe the vaginal estrogens. I don't really prescribe like a hormone replacement therapy because it's not
Right.
something I've been trained on. And we found some um, that the providers on the gynecology side aren't always good about providing that, which is still confusing to me. And it's a little bit of a struggle that we have in terms of communicating. I try to communicate with the provider, could this patient be prescribed some estrogen? And for some reason, there's just it's an ongoing issue, I would say, in terms of providing like the proper care for patients.
That's for the
Um,
that's for the clients that don't have estrogen sensitive cancers, right?
Right, exactly. Yes,
Right.
I should clarify. This is for like advanced cervix. So
Yeah.
even endometrial cancer is a little controversial because it is estrogen driven. So this is for non-estrogen driven gynecologic cancers or gastrointestinal cancers as well.
Yeah.
They're typically candidates for hormone replacement therapy as well. So I think it's huge, but you're right. It's a compliance issue. We tried to get them to put their estrogen on their dilator and use it so that it gets all the way to the top of the vagina. The other thing I see it's a problem with both the estrogen and the dilators is that women don't put them in the dilators in far enough. They really don't understand what's their anatomy is like. Some women don't even understand they have a vagina left after a hysterectomy. It's a lot of just
Mhm.
educating women about what's there, about how far in to put the dilator. I tried to show them like make sure you're only holding a little bit of the tip. All of it should be going in about this far, because they put it in, like 2 inches or something, and then their vagina ends up being about like the length that they put the dilator in. So
Yeah.
those are some really important like educational things as we're looking for interventions. I mean, yes, it'd be great if the laser treatments could work. I think if we could just even maximize some of these other options that we have, um, that those might help as well. I think what the biggest thing we run into is compliance. So
Yeah. Yeah. And a lot of times with my ladies, I have had them use a wand because it has a much smaller tip and they can slide it in all the way better, especially for people post hysterectomy that they have scar tissue pain up around where either the cervix was left or it was taken, and the dilator just isn't going to get up there. So using the wand is nice because it's thin and it's got the long, so they can manipulate it easier. But I think I really am excited about the microbiome because I think there's so much to that, and it's just we're just learning, and I think it's fascinating to. It'd be even fascinating to do such a long perspective study. Of course, it would cost a lot of money, but what women's vaginal microbiomes look like at different stages of their life, and is there people that maybe we can actually predict, like, oh, this microbiome is this is consistent with somebody who is, at risk for cancer versus not, and I think you're really onto something very cool there. And also, like, what changes in radiation? When does it change? And is it something we can reintroduce? Does it make the vagina less acidic? What is happening? What's going on there? And is that maybe what's driving some of the urinary issues as well? So great stuff. This is all a lot of things for people to think about. I also find the work that you're doing with the CO2, fractional CO2 laser, the infrared lasers and things like that. Wouldn't it be great if there was a study showing, post hysterectomy scar tissue up around the top of the vaginal vault with some laser treatments to help make that much more flexible and movable and, help people understand a little bit better about, you know, feeling safe and using anything else that they need to use. But, oftentimes that can be a place that can be quite tender on people, post cancer surgeries, post hysterectomies, post whatever reasons they're having these surgeries. Just another way because we use laser treatment outside the body all the time. So it's kind of like, how can we do this to make things, if there is a population that's going to benefit, wouldn't it be great if, like you said, if we can get it into the hands of more of them and not into the and get them out of the very expensive spas
Right,
where,
exactly.
where only people with a lot of income can really, employ that.
Yeah, it's
So
cost prohibitive for most people. So again, we I don't think that will come down unless we have really good evidence that it should be used more. So that's part of the rationale for doing these studies, is to make it
yeah,
accessible.
100%. Okay, is there anything in particular you would like to leave here for people to just take home, like a good take-home message from today? We talked about so much, but
Mhm.
just give us one, like.
Well, I'm so I mean, I think the work that you guys do is great. So thank you for helping our patients. I think they just, if you can continue to encourage them, understand that for a lot of women, using dilators and just anything vaginal health reminds them of their cancer diagnosis and treatment. So sometimes it's just an area that needs a lot of sensitivity and care. And I think the pelvic floor physical therapists actually do a great job of helping the clinicians with that. So keep encouraging them to be compliant with their dilators and always reach out to the oncologist, particularly the radiation oncologist, if you have concerns. It's a good relationship to have. I feel like I know our pelvic floor physical therapist at Ohio State, and it's been a really good relationship. I think for me to know them, what they do, for them to know what we do, and for our patients for their care.
Yes. When we all collaborate, the client wins. 100%. So, thank you from the bottom of my heart for your time today. This is such valuable information of where we are, what's available, what to be worried about, what not to be worried about, openness of conversations, and the future of looking towards other ways and methods to help these women, move forward, and men, with their back passages and things like that, be able to move forward and make some real progress in areas. And you will send me the link on the sexual medicine conference.
Yeah, I
I will be
will.
sure that that gets into the show notes. If you have any questions for Dr. Quick, you can message me. There was a form sent out with the interview. You can pop into that form and ask some questions, and I will make sure we find some answers for you. Thank you very much for your time, and have
Thanks,
a
Susan.
great rest of your day.
Thank you.